So once we know that the video or the slides are not functioning properly, the speaker is unsettled. And it is difficult. So anyway, it is a thing, it's our daily business, the chest pain. And when you think of chest pain, all chest pains are not alike. All chest pains are not myocardial infarction, and they are aptly given the topic's caption, chest pain beyond myocardial infarction. So why should we are much interested and much vigilant regarding the chest pain? Because this is a cardinal manifestation of a life-threatening illness. But at the same time, it can be the distressing manifestation of a trivial illness. The illness may be trivial, but we have seen people coming regularly to the casualty, frequent visits. It is a distress for them, but we are not able to find out a cause. It could be a trivial illness, but it is a distressing manifestation. And moreover, an improper diagnosis and inappropriate management can cost a life. That's the most important issue regarding the chest pain. And if you look at the epidemiology of chest pain in the primary care and emergency department, around 50% is cardiovascular, and rest are non-cardiovascular, which include even a 9% of psychiatric disorders. I think if we look at our own practice, this may be the cross-section and this may be the correct statistics. And if the US data, it is one good thing about such talks, I don't have much data, so no studies, no data. This is the only data I am showing. 5 million emergency department, with such a large number of people are coming to the emergency department, with 2 million hospitalizations with a cost of more than 8 billion. And 1/3, 30% may have a cardiac etiology, the rest of them are non-cardiac etiology. So it's a huge job on the emergency room people to sort it out, which is cardiac, which is life-threatening, which is non-life-threatening, which is a trivial illness. And at the same time, you should escape from inadvertent discharge of a serious illness. So I think my videos are not working, so there is no charm in showing this thing. A 40-year-old male, he recently, this happened to us, he's a handicapped person. He came with a retrosternal chest pain, which he was seen initially in our own casualty. He had some ST changes in the electrocardiogram. There were no beds in the intensive coronary care unit, and he was referred out to another center where he was lysed. But the patient remained in shock, and 24 hours afterwards, he was referred back to us for an expert management. And I don't know whether you can see the electrocardiogram. The electrocardiogram showing some minor ST elevation, but no reciprocal changes, normal heart rate. Hope it will not work, isn't it? Will it work? No, your boss was saying something that he can do to work it. Yes. If it is do not work, it is okay, because we should not waste time on it. Will it work or not? Work cheyyathillaayirikkum. No, I'll tell you, this was a dissection of aorta. Oh, it started working. Fantastic. If you look at the echocardiogram, the first echocardiogram, my resident was feeling, so there is nothing there. There are no regional wall motion abnormality. The patient is having a normal heart size, a normal or a small RV size, nothing. Then he was, but this is not working, so it is very difficult to show. Just in the 4-chamber view, it was showing some doubtful thing in the descending aorta. Then we extensively did echocardiogram, and now you can see it was a dissection which was extending from the beginning of the aorta, from the root of the aorta down up to the femoral arteries. So this patient was sent for a surgery, but unfortunately it was an extensive dissection. The surgeon did his level best. He stayed for 2 days, and we lost him. It's not a simple job for anybody, and especially following a thrombolytic therapy, and the most important thing is thrombolytic therapy is absolutely contraindicated in such a situation. But this happens only once in a while. I have seen only 3 or 4 cases of aortic dissection coming to the emergency department in the last 15 years. So it is an uncommon thing, but rarely the rare things may come to us. So we should be aware of such things. Not. What?
If the dissection has stopped short before renal artery, would this patient have survived?
That we cannot tell, sir. It's all depend upon the, what you call, the surgeon. Basically, many of the surgeon, what they do is, they'll try to do something by and close the false lumen, compress the false lumen. Usually, what they will do is, they'll dissect the early part of the aorta and do a grafting with a valve. And they have to reimplant the coronaries. Very extensive surgery. Mortality rate is quite high. Another 40-year-old male smoker, diabetic and hypertensive, presented with a history of retrosternal chest pain of 20 minutes duration. An electrocardiogram taken was normal. A troponin I was requested, which came as negative. And since the electrocardiogram was normal and the trop was negative, this patient was promptly reassured and sent back home. And next day at 4 a.m., this guy was brought dead in the casualty. So this is one scenario that nowadays we see commonly in the casualties or emergency room. The patient comes with a chest pain. Nobody bothers to go into the details of the history to see whether it is a real cardiac pain or not. Rather, the registrars may rely too much on the electrocardiogram and the troponin, which may be a premature sending of the troponin, and normal electrocardiogram and normal troponin. The patient was inadvertently discharged and he died. A 44-year-old female, not diabetic or hypertensive, presented with history of left-sided chest pain, and clinical examination was non-contributory. This was the electrocardiogram. You can see the electrocardiogram. Now, retrospectively, it is easy for us to say that it is likely to be a Brugada pattern, but there's a basic thing of there is ST elevation, but it is not a classical ST elevation of the anterior volume, and there are no reciprocal changes. And now, most of the emergency rooms and all the ICUs are equipped with an echocardiographic machine, and if you see such a thing and if you are in suspicion, you just put a probe on the chest and see whether there is a regional wall motion abnormality. If you are seeing an ST elevation and no regional wall motion abnormality, you should be suspicious. And the danger is in non-PCI centers because the option is thrombolytic therapy. And what happened to this patient is he was thrombolized considering an anterior wall MI. She developed a headache and vomiting 4 hours after thrombolysis, and CT revealed an intracranial hemorrhage, and we lost the patient after 2 hours. In suspicious cases, in centers where it is PCI capable center, it is always better to go for a primary PCI. Do an angiogram, see, and if there is nothing, the patient is saved because otherwise the option is a thrombolytic therapy which carries a risk of fatal bleeding. Another 60-year-old smoker, COPD, admitted with dyspnea and severe chest pain. Patient was in hypotension and respiratory distress. This is the electrocardiogram taken. Ramesh sir, what do you think? No, there is some bizarre ST elevation in 2-3 AVF, in V1, V2, and a poor. This is a pneumothorax. This was a pneumothorax. This was a pneumothorax, and you see the ECG after the pneumothorax. It is. Okay, this is another patient who presented in the casualty on a busy day, and this electrocardiogram was shown to the resident. This happens in the casualty usually. He comes, the casualty medical officer sees the patient, and he will show the ECG to the resident. The resident may not look at the patient, he'll see only the ECG, and he ordered aspirin, clopidogrel, and heparin. The patient became unconscious after 2 hours, and the CT revealed a subarachnoid bleed. The entire electrocardiographic changes were due to the subarachnoid bleed rather than, and we added much to the bleed by adding aspirin, clopidogrel, and heparin. Another 65-year-old gentleman.
So what are the changes you will get in subarachnoid?
This is a deep T inversion. Some amount of QT prolongation you can get. These are the things.
Normally.
Not normally, you can get it. This is not a rule that all subarachnoid hemorrhage should have T inversion. But there deep T inversion can occur in subarachnoid hemorrhage, which can quite confuse with coronary artery disease. It is said that it may be due to the increased sympathetic discharge. Nobody knows what is the real pathology. This is another 64-year-old gentleman developed a severe chest discomfort immediately after a heavy meal, and then he collapsed. In the emergency room, in shock with features of hypovolemia. Echo normal, electrocardiogram normal. This I think Ramesh sir will answer. Extremely rare thing, but it does happen. It's a rupture esophagus. So medicine, the problem of medicine is, at its core, it's an uncertain science. It's an incomplete science. It's a very, very beautiful biological science where there are a lot of uncertainties. And I will recommend, if you have time, buy this book, How Doctors Think. It's a beautiful book. How Doctors Think. A lot of insights in this book, because after all, we know that every doctor is fallible. There is not a single infallible doctor on this earth. And no doctor is right all the times. Even the most brilliant makes wrong diagnosis or chooses wrong therapy. And majority of errors are flaws in physicians' thinking, not a technical mistake. So it is the proper thought process that is important. And our training of our students also should instill how they should link their thought process properly so that mishaps should not occur. So the chest pain is the commonest cause of an emergency room visit. It's a resident's nightmare. We were all residents and felt much difficulties and struggled because of chest pain. Because either it could be benign or it could be life-threatening. So two spectrums. If you miss a life-threatening thing, you are doomed. If you overtreat a benign thing, again you are in problems. So if you look at the chest pain in emergency rooms, mostly this is old data, the thrombolytic era, 1/4 to 1/3 are usually acute cardiac ischemia. And majority of them are non-cardiac ischemias. And some are inadvertently discharged, some are even inadvertently thrombolized also at that period. So in our approach to a chest pain, first and the most important thing is look for life-threatening features. If there is any evidence of a life-threatening feature, that has to be identified immediately and tackled. Or is the patient stable and comfortable? Stable and comfortable patient can be quite deceptive, but here mostly you have time. You have time to evaluate. Chest pain, we broadly classify it into cardiac and non-cardiac because cardiologist's job is basically to rule out whether it is a cardiac. Our job is identify the life-threatening problem and appropriate urgent management of the life-threatening issue. Then find out whether it's a benign disease or is there any pathology at all. There are times when there is no pathology, or rather we are not able to identify any pathology. At the same time, the patient is rock stable, so you don't have to worry. The other important thing is avoid the overdiagnosis and overworkup, because it's a heavy toll on the resources as well as the financial status of the patient, because millions of dollars are spent in the Western states for admissions and workup of patients presenting with chest pain. So overdiagnosis and overworkup should be avoided, which needs a real clinical equipment as well as a clinical approach. At the same time, the difficult thing, avoid inadvertent discharges. So first thing to answer is the pain a typical cardiac pain? Or is it a typical non-cardiac pain? If it is a typical cardiac pain, there is no confusion. If it is a typical non-cardiac pain also, there is no confusion. Or does it fit in with a particular non-cardiac disease like a pleuritic chest pain or a pericardial pain, or symptoms are definitely suggestive of a GERD. Most often GERD is the one thing that is a big and important differential diagnosis of a cardiac pain. And this is the fourth one, is the most important thing we are facing. Not sure whether it is cardiac, but it's suspicious of a cardiac pain. That requires a careful approach. And the other one, the pain seems to be non-cardiac, but there are ECG changes. Keep in mind, ECG changes can be due to a lot of things. It is not always cardiac. And whether they need, certain patients do not require any further evaluation. You are all experienced clinicians, you know. Certain patients, the first 2 minutes of interview, you are able to tell that this guy doesn't require further evaluation. He can be immediately sent home. The problem with the chest pain is lot of structures around the heart. The heart, it's covering, and all the other structures. Pain can arise from any disease or any pathology of all these things. So we have innumerable reasons for chest pain. But the life-threatening ones are acute coronary syndrome, aortic dissection, it's not pericarditis, aortic dissection, pulmonary embolism, tension pneumothorax, and rupture esophagus, of which rupture esophagus is extremely rare. Tension pneumothorax you can easily identify with an X-ray as well as the history. Pulmonary embolism, basically the suspicion. The background for a pulmonary embolism, suspicion, patient's presentation is mostly dyspneic rather than chest pain. Aortic dissection is rare. Look for any background for aortic dissection like a systemic hypertension, presence of a features of a Marfan syndrome, and the pain which begins, the onset of the pain is the most severe and a ripping pain, especially along the back and the chest. And look for pulsations, whether all the pulsations are present. ACS, we all know what are the descriptions of ACS. The most important and the immediate DD is the gastrointestinal causes like gastrointestinal reflux disease, ulcer diseases, anything that is in and around the diaphragm, like a disease of the gallbladder, a disease of the pancreas, a disease of the liver, or a diaphragmatic problem. Then, of course, a musculoskeletal chest pain, and finally, a psychological pain. So, if you look at the chest pain by history, identifying angina is basically by history. The typical presentation of the angina, the typical radiation, I don't think I have to describe all these things to such an audience. And a pericarditis, it is a sharp pain. Esophageal reflux, this burning pain is the issue. It is esophageal reflux, sometimes really mimics a cardiac pain. It is very difficult for even an experienced clinician to differentiate whether it is really esophageal or whether it is cardiac pain. Esophageal spasm is an important DD for a cardiac pain. Gallbladder diseases, the burning, pressure, then of course the signs of cholecystitis. Aortic dissection is the ripping pain, and patient is in distress. You may not find anything in the electrocardiogram. And then he may go for a hemodynamic compromise. Musculoskeletal pain has its own descriptions. And a variable pain, sometimes the totally variable pain by description is in emotional and psychiatric disorders, and pleuritic pain in a pneumonia, pleuritis, or a pneumothorax. The most powerful clinical tool to identify a cardiac pain is nothing but this description of William Hubbard in 1768, the classical description of an angina. There is no other, I still remember George Jacobs, he used to take half an hour history to identify whether it is a cardiac pain or not. I think Johnny Sir knows that there was a patient, he was telling the story of a patient, he identified it as effort angina because this guy went up to the coconut tree to pluck the coconut. The first coconut there was nothing, after 20 coconuts he started developing chest pain. So, sir was telling, this is typical effort angina. The guy did not have a chest pain for first 20 coconuts, then he started pain and the pain increased. So, I still remember that story of his. But still the most powerful tool is a proper clinical history. There is nothing, nothing is a substitute for a proper clinical history in identification of angina. Then there are certain characteristics which means it is totally non-cardiac. A fully pleuritic pain, a strictly localized pain, a pain which is fully reproduced with movement or palpation of chest wall or arms, and primary or sole location of the pain in the middle or lower abdominal region. Brief episodes of pain that last for seconds only, and pain radiating to lower extremities. These are extremely unlikely to be a cardiac pain. And if the patient is able to point the pain, then it is unlikely to be cardiac. And the background is important. What's the likelihood of coronary artery disease in this patient? A 20-year-old male without any other risk factors and giving a history of angina, it is extremely unlikely. But nowadays we have started seeing quite young persons coming with acute myocardial infarction. So classical angina, even in a low likelihood person, it should not be ignored. Recently we had a 20-year-old female with acute myocardial infarction, Takayasu's disease, ostial left main. Atypical pain in a high likelihood person needs careful assessment. High likelihood person, diabetic, hypertensive, smoker, renal dysfunction, they present with all atypical manifestations. So a high likelihood person, even if it is an atypical chest pain, he should need careful evaluation. And non-anginal chest pain, in the casualty, you see the patient, we see the patient, it is resident sees the patient and say it is non-cardiac. And when we declare that it is non-cardiac, the other people also may lose interest and they will feel that this patient is a stable patient, there is nothing in it. But he may be having a non-cardiac life-threatening problem. So it is always the duty of the cardiology people to hand it over to the correct specialty to assess whether there is any other life-threatening problem or not. So the diagnostic tools are all simple. These are the common tools that we use. Electrocardiogram, X-ray chest, biomarkers, echocardiogram, and a CT angiography. And if needed, coronary angiogram. Electrocardiogram is the most widely used, simple, repeatable, cheaper, and it is diagnostic in ACS. It helps in the prognostication of the ACS, and it helps in therapeutic decision making. Pericarditis also, you can have typical electrocardiographic findings. But the problems with, there are a lot of limitations. It can be non-diagnostic, it can be non-specific, quite misleading. Because all the problems we are seeing is a misreading of the electrocardiogram. Never read electrocardiogram in isolation. That is the most important thing. And it's only in the light of a limelight. There is no problem if it is a characteristic ECG change with a classical cardiac pain. No issue, no confusion. But if it is a normal ECG or a non-diagnostic ECG in a patient with a typical cardiac pain, that is a problem. Nowadays the problem is the new generation people may not listen to the history. They will always rely too much on the electrocardiogram. If the electrocardiogram is normal, this guy may be sent home, even if he tries to tell us that he is having a heart attack or he had an unstable angina at home. And in a typical chest pain, electrocardiographic changes suggestive of ischemia, and patient may get dangerous therapies. That is another area. So what I want to impress upon is that a clinical approach, a clinical history is the most extremely important thing, and ECG to be read only in the limelight of a clinical background. This was a 29-year-old male with a localized chest pain. Troponin was 2.3 nanogram per ml. It was a strictly localized chest pain. Ramesh sir, കാണാമോ electrocardiogram? There is ST elevation in V4 to V6. Right, because there is ST elevation in minor ST elevation in most of the leads, remarkable in V5, V6. It seems to be pericarditis. The only issue is when we take a serial electrocardiogram, the T started inverting in V5, V6, which is unusual for a pericarditis, because pericarditis, when the ST comes down, the T inverts only when the ST normalizes, because it comes in stages. We did the angiogram, it was normal, this was a myopericarditis. So, these type of changes can occur. This is another 39-year-old male with a left-sided chest pain, and he was lysed with a streptokinase. You can see that it is written post-lysis EC. It seems to be an early repolarization syndrome. This was actually, again the angiogram was done. There was no coronary artery lesion. So it all happens. The problem is, it looks alike, the benign and the deadly. This one snake is very benign, nothing will happen. The other is a deadly poison. Looks alike and it's very difficult to differentiate. So this is benign and this is lethal. So it's the duty of the clinician to differentiate, and differentiation usually in the background of a clinical one. It's a crucial decision because the wrong diagnosis can end up in a calamity. There's a 54 years old female with a carcinoma ovary presented with chest pain and dyspnea. Malignant patient, he's 54 years, coronary is the first one, but if it is not fitting with coronary, then a malignant patient, pulmonary embolism is the second one you should think of. You have to look for this evidences of this thing in the electrocardiogram, like a sinus tachycardia, right bundle branch block, a right axis deviation, atrial fibrillation. Though atrial fibrillation has been described in pulmonary embolism, I have seen only once. That is, recently we had a patient with pulmonary embolism who presented with atrial fibrillation. He was sliced and saved. Sir, I have seen only once. I said the classical description, we lysed the patient. After 2 days, his rhythm returned to normal. So electrocardiogram in chest pain, it's an invaluable tool, no doubt, key to therapeutic decisions. Only thing is, an abnormal ECG does not mean an abnormal heart, and a normal ECG doesn't mean a normal heart. An ECG finding without clinical data can be quite deceptive. So never make any decision based on ECG without the timeline and clinical background. The problems of the ECG are its low sensitivity, single brief sample in a dynamic process. So when the patient presents, he may not be having the ischemia. He might have had ischemia 1 hour back, and the ECG may look normal. And small areas of infarction or even ischemia cannot be picked up in the 12-lead electrocardiography. And there are baseline abnormalities which makes the interpretation of the ECG difficult. And of course, non-specific changes due to multiple reasons. So a single normal ECG does not rule out a cardiac disease, and an abnormal ECG does not indicate an abnormal heart. So in a chest pain, you may require serial electrocardiogram and an ECG at the time of discomfort. The biomarker is a big danger now. I don't know how you feel, but from our casualty, now it is a standard dictum. Any patient who is entering in the casualty will have some chest pain, he'll have an electrocardiogram, he'll have a troponin. And unfortunately, the troponin will be positive in lot of non-cardiac conditions. Troponin positive means only one thing, there is a myocardial injury. Then this myocardial injury, is it due to ischemia or not? The clinician has to take that call. Whether it is ischemia or not needs an evaluation. All TROP-T elevations are not ischemic. TROP-T elevations with myocardial injury, which has multiple reasons, including cardiac and non-cardiac, and many non-ischemic causes for myocardial injury. So sorting out the TROP-T elevations reason is now the biggest job of a cardiologist. Johnny sir anganeyano. So chest pain, you can be either definitely coronary, cardiac, non-coronary, with a diagnostic certainty, like a dissection, a pulmonary embolism, a pericarditis. Then it can be definitely non-cardiac. Cardiologist doesn't have to worry about it. It is non-cardiac. He says it is definitely non-cardiac, no doubt about it. But definitely non-cardiac can be an esophageal rupture, it can be a cholecystitis, it can be a pancreatitis, which are all important diseases and diseases with great morbidity and even mortality. And non-diagnostic or uncertain, this is an area which is difficult. And here he may be extensively evaluated. What cardiologist does is, we'll do a coronary angiogram, we do an echocardiography, and then we'll say there is no coronary, there is no structural heart disease, hand it over to the physician for further evaluation. But 15% of the patients in many of the major centers have been, even after extensive evaluation, have been found to have chest pain of uncertain etiology. We do not know. The patient may be having a real problem, but we are not able to identify it. So a chest pain of uncertain origin, cardiologists look for a serial electrocardiogram, biomarkers, echo, CT angiography and coronary angiography, and we brand it is non-cardiac. We will not be diagnosing, but we will tell them that it is non-cardiac, no life-threatening cardiac problem. So far we are able to identify no definite cardiac problem. Whether there is another life-threatening problem or a serious problem or a definite pathology, he needs further evaluation. So I think chest pain is a difficult problem, but experienced clinicians are able to make a correct diagnosis in majority of the cases. Inadvertent discharges or over-treatment and over-workup is much less in our part of the world. And you are all experienced learned clinicians who are able to, who might have seen much more number of chest pain and problems than me. So the problem is how to make the correct diagnosis. There is no single script that every doctor should follow. The essential tool of clinical medicine is a combination of thought and action, and it's like a flesh and blood decision making, especially in chest pain. And most errors are mistakes in thinking. Working in haste and cutting corners are the quickest route to the cognitive errors. So let me conclude with a single message. Still, clinical medicine is important. A clinical approach is the utmost thing. Thank you. കുമാർ ഇടയ്ക്ക് പോയവരണം അടിച്ചു തന്നെ അതിൻ്റെ വില സംശയം.